Yeah.
So the day today is, of course, very special because of the World Teachers Day, the 5th October. The third masterclass, we are having two sections. One is actually the interaction discussion with the pathomechanics and the principles of examination and treatment. Because pathomechanics goes parallel with what we are actually going to do in a functional evaluation and treatment. So we'll see today's session, where first is the discussion and interaction for the questions received in the WhatsApp group, and then followed by the pathomechanical principles. So Dr. Darshana will read it out, questions which are posted by everyone, and we move on today's session. Yes, for wrist and hand instability.
Yes. So the first question we have today is by Dr. Shashwati. She's asked, so one patient had click sound in wrist extension, end range. Extension is painful, 4 to 7 on 10. Taping the ulnar in posterior direction relieves the symptoms. Sir, is it for the ligament instability? And what is the treatment in this case? End range.
This kind of a scenario, what was described, actually shows the treatment-based diagnosis, okay? Where you don't know where the instability is, whether instability is there or not there, but you found that stabilization was helping the patient. This is an external stabilization. So I assume that it is a rigid taping. Okay, so if it is rigid tape, always it supports the ligaments or the capsules. If you are putting a kinesio tape and the subject feels relief of symptoms, you can always tell it is a myofascial underactivation or overactivation. So you know the direction of kinesio tape, origin to insertion is facilitated. So if that is relieving the symptom, you can think of an underactive muscle. So it got facilitated, so you are getting relief of symptoms. Another is insertion to origin for kinesio tape will be like inhibitory, which is again like it will relieve the symptom if there is a overactivity of the muscles. For spasm, I will not prefer the kinesio tape, even inhibitory. I will prefer the perpendicular orientation of the rigid tape. Okay, so if origin to insertion is there, this is about the muscle. But this muscle spasm can come with ligament tears, especially the partial tears, or it is with autonomic disturbances or central sensitizations. So in all the three situations, whether peripheral or central or autonomic, you will have a muscle spasm. So when you have a spasm, the rigid tape which is put perpendicular will relieve the symptom of spasm. And the spasm can be there irrespective of instability also. Because if there is a degeneration also, spasm can come. If there is a tendinitis, that same muscle will go into spasm. Okay? So multiple things can happen. So spasm can be a result of even a nerve injury. Okay? So you cannot tell that it is an instability because of ligaments, but you can tell instability. I will always advise, when you are talking of instability, think of articular instability, myofascial instability, and neural instability. So I extend it to all the three categories. So that means, for example, articular instabilities, which we are all very clearly aware, hypermobility, clicks, and ligament laxity, accessory movements increased and all that, okay, articular. But when it comes to myofascial instability, it determines like partial tear, or it could be a total rupture of the same musculotendinous unit. So that the muscles become what is called as underactive. Okay, so then you can characteristically tell it is instability. If it is having spasm, it is hiding the instability that is in the muscle. Okay, so even a ruptured muscle can be told as myofascial instability. Okay, and the same way you see for nerve injury to the nerve, only the connective tissue sees the injury. Only the myelin sheath or till the axon premises or neuron premises. So you can grade it as again instability there also. Like how ligament grade 1, 2, 3 injury. Same way muscle is also classified. Okay, muscle strains and sprains. Okay, and then partial tear and complete tear, which we are already aware. So in addition to that, neural is also instability is possible. Traction injuries to the nerve might create trauma to the nerve, which will create again instability of the nerve, or excessive what is called as the nerve's tendency to get ruptured, okay, when you give a tensile loading. And whether the nerve will be more mobile. One thing is, if I am having a droopy shoulder, that means the brachial plexus is more lengthened, okay, the traction force on the brachial plexus. So after that, if I'm just moving the neck, a normal plexus movement versus a lengthened brachial plexus movement, definitely you can assume logically that lengthened brachial plexus will move more than the normal plexus. Okay. So this way, instability could be a lengthened neural issues, which is symptomatic upon injury. Okay. So there is a partial injury or anything. Otherwise, it will be just asymptomatic like hypermobility of joints. So if a tape is relieving, rigid taping, so it could relieve any of the aspects. Okay. So think of ulna posterior, why it has to relieve. First and foremost, it influences the distal radioulnar joint. So for example, here ulna is there. Okay. So this is ulna, this is radius. So ulna posterior. Okay, and then I am applying the tape, okay, in the dorsal side. So I'm taking the tape from here and applying it to the radius. So it actually makes the radius to be anterior, and it helps with the pronation. And you are actually stabilizing the distal radioulnar joint posteriorly, okay, because the rigid tape will come towards posterior. Okay, so dorsal, what is called as inferior radioulnar ligaments, thickening of that capsule, okay, that which is the inferior radioulnar joint. It's not a synovial joint. It's sometimes classified as pivot joints. Okay, these radioulnar joints. The middle radioulnar is membranous joints, which is fibrous. So what we have to say is, you are stabilizing it into pronation moment of the radius, and the subject is feeling symptom better. Remember one more thing with radioulnar joint. Supination is close packed position, which is actually articular stability. Joint is compressed. There's no accessory movement possible in supinated position. But if you do a mid-prone, definitely more mobile. In pronation also, it is a slightly more mobile than supination. So mid-prone is the loose packed position, but pronation is not a close packed position. Okay? So you will get movements in pronation more compared to in supination. So you are not actually blocking or stabilizing it. You are only stabilizing only posterior side. Okay. Anteriorly, it's not stable, and you are also facilitating a pronation movement. Okay, by posterior directed taping of ulna. I think the attempt was made to do the tape after the MWM by giving the posterior glide to the ulna and seeing that the subject is feeling relief of symptoms. So you have put the Mulligan taping, okay, the same direction. So what is important here is to understand the mechanics behind and see that it is not actually blocking the movement of the joint. It might block the supination. In supination, what could be the instability? It's very rare. Okay. So pronation is the loose packed. So you will not get an instability in supination. Okay. Another thing which you have to think is also between the pronator quadratus. There is a muscle here. Okay. In the distal, from the distal ulna to the distal radius. Okay. Horizontally. Pronator quadratus. So this actually creates the pronation of the distal radioulnar. This joint, this muscle, if you are putting on the ulna and then taking it posteriorly, means it will lengthen the pronator arteries. In a sense, if you are taping the radius into anterior direction, it will shorten the pronator arteries. But if you are taking ulna and then posterior, means it will lengthen the pronator arteries. But the muscle can actually activate better when it is lengthened. Okay, because we are not inhibiting the muscle with perpendicular taping. We are only putting in the attachment. Okay, so optimal length of the muscle can actually create a better activation of the muscle. So pronator teres, whether if there is a trigger point, latent trigger point. The latent trigger point usually will be like relieved with direct pressure, ischemic compressions, or post-isometric relaxation, which is like facial distraction or isometric resistance and then supinating, okay? And then again supinating after multiple repetitions. So you can do multiple things for that, okay? But here you have kept the ulna lengthened, so the pronator teres is becoming like released, okay? Because of the lengthening, the posterior direction taping. So it could be even a trigger point, latent trigger point in the pronator teres, okay? What I am trying to tell is, first and foremost, palpate the patient. First palpate and see how the radial styloid processes, how the ulnar styloid processes. Okay, whether the radial styloid process is inferior compared to the ulnar. These are all anatomical landmarks which is there in basic text. The relative anatomy, surface anatomy, bony landmarks, which is anterior, which is posterior. Okay, skeletal. If you find abnormality when compared to the opposite side, the other side upper limb also you are palpating and you are seeing, okay, and you get an this is a symmetrical one, but here you find that the radial styloid process is more posterior, okay, then you know that it is supinated, okay, when radial styloid process is posterior. If it is anterior means you know that it is pronated. So this is something which you need to understand in your movement itself. You don't need a special biomechanics class. What's important here is to see, if you don't palpate, you will not know what is the resting alignment, what is the tissue, which tissue is problem, okay? And directly you just do an MWM and taping. You can be a certified malignant practitioner, but you are not a clinician. This is what I was trying to tell with technique-centeredness versus patient-centeredness. So that is where you will palpate and see that, and the palpation also, bone palpation, you know how it is hard. It will not be influenced by anything. Ligament palpation between bone and bone. There are bony landmarks, bony landmarks. So you keep one bone stable, move the other bone. Either it is the joint between that or it is the ligament between that. So ligament can always be stretched also. If medial collateral, I have to stretch. So triquetral or pisiform with the ulna. Lateral collateral or radial collateral, I have to stretch. So scaphoid with the radius. Okay. So specifically, I can move into a radial deviation or ulnar deviation, which is called as the valgus varus test. There's nothing special about those tests. Okay, they are simple movements which will elongate the ligaments. And we also know that when it is elongated, it can be just the ligament tenderness, or it could be even the flexa carpi ulnaris. So that is why what we do is we give resistance, ask the patient to do an ulnar deviation. Okay, so he will push my hand here, and when he is resisting, that time I am palpating, and it is more painful. During isometric contraction, it's more painful. You should suspect that it is the flexa carpi ulnaris tendon injury rather than the ulnar collateral ligament, because it's the principle of examination what we usually discuss in AOMPT, that muscle contraction will test the muscle only. So it will pain if the musculotendinous unit injury is there. But if it is ligament injury, it will not pain. It will reduce the pain, because active forces will stabilize the joint also. It will hide the ligament that is deeper off. Okay. So these kind of examinations are elementary. And another thing, I might get what is called as with the radial deviation. Okay. With the radial deviation, I am getting pain here in the medial side of the ulna. Okay. So immediately what I should do is, I should have a curiosity to see whether it is extension which is increasing the pain or whether flexion is increasing the pain. Okay. And then the next one, shoulder abduction, whether it is changing the ulnar region pain here. Every time I should think of all this articular myofascial and if you do not getting that perspective, somehow you hit your head anywhere. But make sure that do not forget this. If you are not learning this after attending this course, or it is a previous course of AOMPT, see, anything you cannot do. You are a victim of your own habits, and don't do any courses at all. It's not just for the therapist alone. I'm telling for everybody. What is important here is to see that as a clinician, examine all the three. Just because certified practitioner, they didn't tell all those things, it does not mean anything. But if you are a member of AOMPT, you should know that differentiate all the three. So if there is a tenderness, if there is no tenderness, absolutely no tenderness, can it be possible? Patient is telling pain is there. Okay. Obviously, I will ask him on what activity it is paining. So he will tell that it is gripping the ball, paining, or using a spanner, or a door handle, or washing the clothes. Okay. Whatever the activity. So give that object to the subject and make him to do functional evaluation. This is what I was highlighting in the elbow. And during that, whether pain is getting reproduced or not reproduced, first thing, only with the activity, leave it on the patient. Next thing is not getting reproduced even with that activity, okay? And you know that it is non-irritable, so you can provoke the symptom. So then where you are doing is, you can give forces to test, okay? So even if he is gripping, okay, he is gripping, you can give force on radius or force on the ulna. Okay, here my thumb is applying pressure on the ulna. If I keep it like this, my thumb is applying pressure on the radius. Okay, so I am stabilizing ulna with my index and I am giving pressure with my thumb here on the radius, posterior glide to radius. So I can influence many directions. Okay, if both my hands are free, I can do anything to superior radioulnar joint also. I can even give to the shoulder or thoracic spine also during the functional activity. I can check any region's influence, okay, within functional activity. And I can easily see that if the patient is gripping, okay, during that pain is not coming, but he is gripping and he is telling, now I am not getting pain. Give the compression to the inferior radioulnar joint. If there is inferior radioulnar joint kind of instability with impingement, only instability will cause only clicks. Impingement is synovial membrane or capsule getting compressed between the bones. So this can happen with the instability. So when I do the compression, the pain will come, which will suggest that either arthritis, distal radioulnar arthritis, or it is an impingement. But you know that arthritis will have early morning stiffness and easing with movements if it is degenerative. If it is non-degenerative, it will not ease with movement. These are all the skeletal things, which I may be repeating maybe 100 or 200 times. But what is important here is to keep that in the mind. Articular, myofascial, and neural. And the next one, without evaluating the patient, there is no treatment-based diagnosis. You don't do too much of a trial and error. Because MWM is very elusive, especially when wrist and hand is there. If it is elbow, it's fine. MWM, very good effect. Okay. Shoulder also, it's inconsistent. Okay. Scapula, it might help. Sternoclavicular, it will help. Acromioclavicular, no. Humerus also, till 120 degrees, it might help. After that, it's very tough to give the glide. Okay, in MWM, technically. So remember that there are a lot of limitations of MWM. You cannot use it just blindly everywhere and say that it is relieving. After relieving, you want to know what has happened. Okay, it is like you have closed your eyes and then you stood in a lift and then you reached the 25th floor. After that, you are asking what happened. Okay, so what is the important thing is keep the eyes open, keep the mind open, evaluate, see floor by floor. I'm not telling that spend 2 hours and then do a big examination like your preparation for postgraduate exams, practical exams. But at least as realistically, 15 minutes you can examine. The screening questions are very simple, tests are very simple. What we have been demonstrating a multitude number of times. So please emphasize that. Then you will know that every technique has effect on joints, muscles, nerves. If it is only gliding also, it has effect on the muscles also. If you are doing myofascial release also, it will have effect on joints also. Nerve also, because nerve is the interface is the muscle or the joint. So don't think that it is only that technique is only for that system also. I am telling this is majority. Articular is tested with this, but it does not mean that glides are only for articular. That is why in many of the techniques and master classes, I have been advising that you can give the glides in the neurodynamic position. In the neurodynamic position, you can give the glides to pisiform. If it is ulnar nerve neurodynamics position, you can give glide to the pisiform. So I am actually mobilizing the pisiform, which is just adjacent to the ulnar nerve. So it should be logical. I cannot mobilize the scaphoid in the ulnar nerve position. Okay? But still it might have an effect. It's like we cannot tell it is not in play because it's human body. What the mechanics the patients are suffering. Okay? So try to see that static palpation, then dynamic palpation. Dynamic palpation is palpating radial and ulnar striatal process during the gripping action and finding that which is going anterior, posterior, or which is coming anterior. Okay? Whether they are separating during the gripping. Okay? Or whether excessive pronation is happening during gripping or excessive supination is happening during gripping compared to the opposite side. Grip strength also you compare both the sides. Okay? Because you need to get that measure as a post-treatment outcome, how much the grip improves. Pain reduces, grip strength should improve. So that way you have to concentrate on multiple things. Right? So ulna posterior one, you can think of radio-ulnar instabilities, or it could be myofascial aspects of pronator quadratus, or it could be even I am thinking of ulnar nerve, how it will come. Okay, yeah, ulnar nerve can come because you are helping pronation. Pronation is actually the component of ulnar nerve. Okay, so you are elongating, and also ulna being pulled posteriorly is also going to create what is called as that space, because the nerve is coming medial, lateral to the pisiform. This is pisiform. So lateral to that. Okay. So if ulna is pulled posteriorly means the space for the ulnar nerve increases. Okay. So it is like the tunnel is there, nerve is there. You have pulled the ulna posteriorly. So that means there is more space for the nerve one way. And then the pronation is actually loading the nerve. So there are influences at every level. Why we are not able to find out even after the effect of the taping is because before the taping we have not noticed what is there. Right? So now it's a differential presentation, what I am trying to do. The same way your evaluation has to focus. Be it even a finger, a simple finger and then collateral ligament injury, only you know it's a fall. But still, you can give the MWM and ask the subject to bend, pain is less, you're corrected. You can put the rigid tape to the lateral collateral ligament, PIP of the index, the proximal interphalangeal joint. Okay, the treatment is not done. Why the strain happened or sprain happened? What is the functional activity which was difficult? Is it just movement, or is it writing, or is it like holding some support or weight bearing? What is that thing? Okay, which is concern for the patient? I have to explore. Because we as human beings will not have only one thing telling that, sir, I have pain. We should ask, what are the other things which were painful or not painful? We have to clear that. And then see that in that, whether what is called as the finger position. More abducted, more adducted. It will tell about the intrasay. Because palmar intrasay adducts, dorsal intrasay abducts. So why this finger is abnormally abducting? Maybe a palmar intrasay is weak or dorsal intrasay has a trigger point. Okay. So these things have to be evaluated. So again, you have to palpate and see. There also you have to resist the abduction and see. Okay. And then if the pain is there, which is hidden and trigger point, patient will not have present symptom, does not mean you will not check. So you will do the movement assessment, you will know that the finger is deviating, abducting. So you should think of which are the muscles which are abducting and examine them. Adduction also you have to examine for weakness. Think logically as a physical therapist, as a clinician. I'm not telling anything extraordinary. It's the presence of mind for the justification of your degree. As movement scientists, which you are proudly boast of, we all. But we should see this. Why it will go like this to strain the ligament here? That means either these muscles are weak or these muscles are overactive. Somewhere you have to get the picture. And then PAP flexion. So which is the one which will flex the PAP? Flexor digitorum superficialis. I should think of extended position of finger, close packed position, PAP. But the moment it is flexing PAP, loose packed position. Loose packed position, only the ligament can go for injury. So whether superficialis, is there any latent trigger point? You just have to remember that which are the structures near this collateral ligament. That's all. I'm doing only that. Finger means which are the structures attaching to the finger. Maybe if you buy a bones like this, it gives these attachments of the intrasay and all. Okay. But still you remember that here also attachment for superficialis insertion, the profundus insertion. Okay. All this. But in patients, this has to come automatically when we are observing. Otherwise, you are not treating the patient, you are only treating the ligament. And we have just to put the tape and then it is done. Okay. So that is why I am telling, be it any disorder, there is always 3 stages of progression. One is dysfunction, next is instability, last is stabilization. This is the degenerative cascade model for low back pain and also for all musculoskeletal pain, it will be applicable. So it starts with dysfunction, that means out of contact of the surfaces. After that, maybe degeneration and then instability because of capsule laxity. Okay. And then last one, stabilization and the deformity. Connective tissue disorders, dysfunction may not come directly, okay, only this like that. It will be because the ligaments are unpredictable. They can suddenly become tight, taut, weak. Okay, they can get into cross-linking and adhesions. It's because it's autoimmune disorders. So those situations, sometimes if I'm overusing my finger, next day my finger deformity will be more. It's like whichever joint you are overusing, you are going beyond the fatigue. Immune system will be accelerated, and after that, those ligaments and capsule will be damaged overnight, and the next day patient will have another deformity in that region. Okay, so this is rheumatoid arthritis. So it will not be like, if that deformity is ignored without treatment, then it stays more fixed. Otherwise, it is a dynamic deformity. Another one is maybe fibrous. Then after that, it becomes ankylosis. Okay. So deformity is a fixed stage. Deformity is caused by instability. Deformity will not cause the instability. Okay. In most of the situations. But if you see genuvarum, You're seeing the knee joint. Okay. We are aware of this genu varum. Okay. So when genu varum is there, here also genu varum. Okay. These ligaments are there. It's very strong. So here it is genu varum. That means medial compression. Lateral stretch. Tibia also is shifted laterally in the genu varum. If you see X-rays of genu varum, you will see a lateral shift of the tibia. So that means genu varum is a deformity, but lateral translation is an instability. Okay? That lateral translation could be before the bending or bowing of the knee. It can aggravate because of the bowing and degeneration medially, so more and more laterally it can go. Finally, it goes into bony ankylosis again, fusion of the knee. So it's a combination. Why the deformity comes? Why the joint goes out of place and then gets getting stuck. It goes out of place means instability is there. If the deformity is aggravating, then also instability is there. If the deformity is fixed, no instability. Okay. So that is the stage when ankylosis is weaker. But fibrous ankylosis will be with the instability. Like what we have as TB of the joints, musculoskeletal TB. So TB hip, it will heal with the fibrous ankylosis. So that will be creating a pseudo-arthrosis. Joint will be like moving around. Fibrous structures are just connected. There is no synovium. All are destroyed. Upper end of the bone also will be destroyed. And only the fibrous ligaments and the capsule. These fibers are also, they are altered in their property. They will not be as they were anatomically correct. Because the infection and the immune reaction there. And also the medications. So finally you find a fibrous ankylosis, which is like unstable hip. Okay. So those times, surgeons might decide if you want a stability means they will do the Arthrodises, okay, fusion. If you want more functional this one, you can do the replacement surgeries. But unfortunately, they don't do the replacement because muscle strength won't be good. These patients will have muscle weakness, so they will not do. In the wrist, when it comes to Arthrodises, they will keep the wrist slightly extended 20 to 30 degrees, and then they will do the Arthrodises fused. So that is also possible. Still, we will be functionally able to do all the activities, be it dominant or non-dominant, whichever side. The functional position is the 20-degree wrist extension and mid prone. Okay. So that is for the systemic disorders. Okay, how we approach. But what I am trying to tell is have this multiple perspective. If a patient with rheumatoid arthritis comes to you, having a deformity means you know that it's because of the instability only. But that instability can be not only connective tissue effect, which is articular, it can be a fatigue effect of the muscles, which is aggravating the deformity every time. And there will be a nerve which will be lengthened, definitely. If I have a wrist drop means radial nerve is lengthened. If I have a what is called as a radial deviation, then ulnar nerve is lengthened. If I have wrist extension means medial nerve is lengthened. So how I know that? It's because components for the nerve and also plus anatomical knowledge. Where the nerve is. Pronation will lengthen the radial nerve. Supination will lengthen both. What is called as wrist extension means both you will get a lengthening. Pronation will also lengthen the ulnar nerve, okay, because of the diagonal twisting. Okay. So remember that ulnar nerve can be stretched more in pronation, but they can be stretched in supination also with radial deviation. Okay. So ulnar nerve can be stretched at the Guyon's canal, just next to the pisiform. Okay. If I show closer, you can see that here is the pisiform. This is hook of hamate. Okay, this is pisiform. So between that is the Guyon's canal. Okay, the canal which is you can see here. Okay, that is the Guyon's canal. Okay, pisiform, hook of hamate. Okay, So anatomical knowledge is important, right? Biomechanical extension of that knowledge is again important. And the reasoning and the examination, the multifaceted. So if a patient is not getting symptoms, I'll provoke all three in combination. So I might give a joint compression to provoke the joint, intra-articular, or I might give a pushing of the ulna or the radius to provoke the segments. Together, I will give a gripping action, which is myofascial, and I might move the upper limb into abduction to load the neural tissues. That is which is called as the arthromyoneuromaneuver, nothing else. That means I am combining all the three together, because individually I am not able to find a elicitable sign to reproduce the patient's symptom. Patient has told that weight bearing is paining. So in the weight bearing position, still I am not able to find. That means keep the hand in weight bearing. When it is weight bearing, intra-articular compression is there. Still you can give the glide and see which direction is restricted. Okay, and give that pressure. After that, abduct for the neural component. Okay, so just to move the body also, abduction will happen in weight bearing. Or neck movement also, weight bearing neural will happen. Yesterday I was showing you that only. Very, very simple to think of these all components. And then you see for contractions, I was showing with the Thera loop. So you can attach that to any of the segments. So when he is weight bearing, intra-articular, I can give the glide. Okay, I can do the lateral flexion of the neck and also give the muscle activation in any direction, anterior or posterior, okay, or medial or lateral, and see that which muscle activation can provoke the symptoms so that I have to diagnose, will relieve the symptoms so that I have to treat. Okay, so if patients have symptoms, I will look out for which one is relieving. If patient do not have symptoms, I have to see that which is the combination which is provoking. Without provoking the patient's symptom, if a subject comes with no pain, and if I am not able to elicit that pain, I am not a clinician. You have not diagnosed. Blindly, you cannot just give treatment and then tell that you have treated. Okay, and you know that patients will be, when you ask them 10 questions and ask where is the pain, in what it comes, they'll be getting frustrated, like why in presence of the doctor pain is not coming. When I'm doing the activity, pain is coming. Okay, so when you are as a therapist, it's your responsibility to get the pain. Then the patient will tell, yeah, this one only, exactly. Yeah, that's the pain. They become so happy that you got the pain and you will remove it. That's the placebo. Okay, so patients who do not have pain also, or less pain also, you should see that the exact pain, what is actually producing. When it is non-irritable, you can reproduce and then treat. Okay, if the patient has a highly profound pain, don't do this. You will do towards the relief direction right from step 1. Patient will feel better and better, and they'll be more happy anyway. Okay, so don't miss these steps. Okay, and then ask like, how did I come here? You are not kidnapped. Okay, you are not a child where somebody kidnapped you with giving chocolates with drugs. Okay, so after that you wake up and then you see like, oh, where am I? What am I? Okay, no, you are the clinician who is responsible. Okay, you are the one who is handling the patient. How can you tell that it is like you became drowsy because of this hijackers giving something? That I can agree. But you sleep in the way and then after that you don't know where you are reaching means in a metro, okay, train. So that means it is like our own negligence. Understood? So make sure that this comprehensive picture, which I have been always again and again re-insisting, the hand model of rehab, where central sensitization, autonomic, AM and MT, articular myofascial neural, that also. And here in this course, specifically in the initial first discussion of functional recovery protocol. Okay, so these are all the things. When I'm telling something, the question should be an advancement of that. Or at least you should tell, I did not examine the articular, I didn't examine the myofascial, I didn't examine the neural. But what could be the problem? Okay. Make sure that the knowledge should not know that you forgot it. Or the knowledge should not feel upset that you are ignoring. It has come as a guest to your house. Second day, you are again asking, what is your name? It is like that, it should not be there. Then knowledge will tell, you be as you are, you will go. So that is why I am telling, in all your interactions, improvise with the earlier knowledge what is there. At least in that course, what you are getting. So get that. I'm not expecting 100% perfection. But it's about 9 minutes video, another is 7 minutes video. These two to think in that perspective and then list the question itself. Understood? When you do that, automatically you will find a change within you that you are really getting better, long term better. Otherwise, short term you will feel course is extraordinary. After the course, again you will be doing the same old things. Understood? So, yes, Darshana. Next question.
Yes, sir. Yeah, then the next question is by Dr. Nitin. He's asked, sir, in case of rheumatoid arthritis, the Z-shaped deformity of wrist and hand is due to ligament and capsule instability.
So as I was just a while before, I was explaining that every deformity is a result of instability only. Okay. The only thing is connective tissue disorders have its unpredictable behavior. Whichever overuse, and after that, whichever joint position we are keeping overnight, next day the deformity will be there. That is why night splints, rest splinting, all these are given. And activity pacing, what is called as joint protection also, and energy conservation also. Okay, in rheumatoid arthritis, so that the fatigue effect don't set in, and then night splitting will protect the joints in functional position. Okay. If you are going to give treatments to such kind of deformities, you should not use end range stretching techniques. Okay, because that will also again what is called as dangerously activate the immune system. Okay, you are not going to provoke the correction of the deformity and accelerate the autoimmune response. Even exercises dosage itself should not be too much, which will accelerate the autoimmune response. So you should remember all this. Then only the success of treatment lies in a descending inhibition and an adaptation, functional tolerance, prevention of complications, okay, when it comes to connective tissue disorders. So they are also functional goal only anyway. But you have a priority in not to aggravate by provoking the immune system. Okay? Provoking immune system is not just by infections. Even exercise, over-exercising also will accelerate the immune response. Right? Next.
Yeah. Yes, sir. So then next question I had asked, what are the common functional dysfunctions seen in subjects with wrist ligament instabilities? Like, for example, I said, students have pain while writing, in their wrist or fingers actually. And can it be due to ligament problems? And can you please explain the pathomechanics for the same?
Pain in writing, but where is the pain? So is it hand pain, or is it forearm pain, or wrist pain? Okay. Either way, one thing you remember that the activity is like 2 hours, 3 hours at a stretch. So it comes in our classification where functional and then repeated overuse or repetitive loading. Resting, there is no symptom. It's not a static symptom, or it is not a dynamic symptom, or it's not even an open or closed weight bearing. This functional activity overuse. So it fits into the classification. So you know that it is part of the picture. The next one is what you should see is, depending upon a pain region, which I told, of course, the earlier description I told, palpation is important, of course.
Yeah.
You have to reproduce the symptoms by distraction with the resistance of the muscles, gripping, distraction, gripping, compression. Okay, both the times.
Yeah.
If it is to do with writing, then what happens is the writing position you can check. Okay, and then afterwards, you will have to do an experimental one of this cohesive taping. Okay, where it is elastic in terms of not able to find the end of the tape. Yeah. So you can take a thinner end. Okay. Take this tape, and it is very simple. It sticks to itself. So I can cut it along the length, make it smaller. The advantage is I can test specifically whether only for the distal radioulnar or the proximal carpal row, the distal carpal row. Okay, so I can specifically see that if it is more thinner. Okay, so like this length, breadth. Okay, so then I can fit around and then ask the subject again to write. But it's still tough because 2 hours of writing, how will you be very patiently observing? Sometimes the writing environment may be an AC hall. So the vascularity will provoke the symptoms. Yeah. So that times I will ask history like whether lowering the hand and then shaking it relieves the pain. Usually in writing it happens to all of us. It is because of arterial insufficiency, writer's cramp, which is myofascial.
Yes.
Venous, very rare, but that also you cannot rule out. Okay, you should think of it because hand is below the heart level. So when the subject will do like this, or do like this, okay, or do like this, after that it relieves. That is venous. So every picture comes in the plan, okay, in our evaluation. Aggravating factors, relieving factors, where are we taking history? Shorten down the hypothesis. Combined testing you can do in non-irritable situation. But this is an endurance related activity. So it's very tough. It is like a marathon runner who's getting foot pain after running for 25 kilometers, 20 kilometers, something like that, the final lap. So how will you make them run in the treadmill for around 4 hours? Okay, yeah, or 3 hours. It's very impractical. Okay, so that is the stage when you will have to find a balance between the two, and also get it from history. Then tell the patient that go and observe, come and tell me. Okay, because initially the patient may not have been aware. Okay, what are the things that were there? So once you will educate and inform them, they can do better job, and they'll come back and tell that this I was having problem. Yeah, I noticed. I took a warm water shower. I felt better. Okay, so everything will fit in the picture. Then you will know that it's more of a writer's cramp, which is a myofascial disorder. But if you think of ligament instability, can it cause? Means it can cause tendinitis. Okay, because the joints are unstable, the tendons are insufficient. So going for like a trigger finger, a trigger thumb, okay, or that's all. Okay, tenosynovitis, the tendon ones, or decolon disease also. Okay, so these kind of things can come because of carpometacarpal instability or because of metacarpophalangeal joint instabilities. Okay, for the superficialis and the profundus tendons. So instability can cause tendinitis. Instabilities itself, it is causing pain as of overuse. Proprioceptive related, and then fatigue. So the finger proprioception not there, then ligaments are getting strained. holding the pen and writing, ligament strain, abnormal position of holding, technique of holding, or maybe what is called as sometimes what the subjects do is they're too much concentrating on exam or tensed. The sympathetic nervous system is overactive. So what you tend to do is you might hold the pen. Normally you are going to hold in the beginning like this. Okay. As the progression of writing happens, the subject will be holding more than what is required, very tight. Okay. Overactivity. Why that overactivity is because of sympathetic overactivity. So that is stress, time shortage. See, why 2 hours of writing after that? Why? When the faculty announces half an hour left. So immediately, okay. So that time what will happen? Ligament is likely to get strained because of the too much of pressure and then position of the joint. So ligament can get. So after writing, but this is not actually related to overuse. It is related to the stress. It's related to the position of the joint that's kept. Okay. So these things again, it's a how I am able to answer is because I am thinking that I am giving the exam now. So when I am putting myself in that situation and then I am thinking I can give these options. Okay.
Yeah.
So otherwise, you just think in terms of flexor digitorum profundus or superficialis, medial or lateral collateral ligament.
Yeah.
Okay. No. Okay. So that is why the treatment can involve even biofeedback for relaxing the muscles. Even upper trapezius activation, overactivation will create what is called as neural alteration. Okay. So there are a lot of things because here overactivation it will block the brachial plexus if upper trapezius is overactive. So you might keep it like this. Okay.
Yeah.
So writing, but how the inputs will come, motor inputs, it will not be coming properly because the interface is closing.
Yes.
Much overactive. So the functional activity when I observe, I'll get the picture there.
Right.
Or when the fatigue sets in, whether thoracic going for more kyphotic. I can think of sympathetic nervous system loading, ganglia, then stress adding on. And here sweating is there. Excessive sweat in the hand. Because of sweat, it is like every time and then again writing. And because it is sweat, pen is slippery. When it is slippery, too much of force to hold the pen. Okay.
Yes.
So it's all a combination where that biopsychosocial cycle comes to the picture there. Okay.
Right. So
that is why the specific symptom of writing comes. 10 patients are there, they will have 10 different presentations. Okay. So that is why we have to see the differential evaluation and help them functionally. Basically, instability is very easy. Use this. Okay. If it is writing, don't forget that. So with this, you can see that which one is stabilized, the patient is getting better. Okay. Rather than the taping, which will actually block the efficiency of performance in writing. The cohesive taping is better than the rigid taping. Okay. It will allow movement at the same time. It will stabilize.
yes.
Right.
Yeah.
Next question.
Go to the next question. Next question is by Dr. Sharvani. She's asked, so a lot of times patients complain while doing a push-up, they experience pain in the wrist at a particular point. Is it because of ligament laxity or a bony issue? How can we differentiate it?
Minutes before, I was highlighting on impingement related to the instability. Okay. So that is the picture there. Okay. Where push-ups is causing localized pain. It's an impingement. Impingement can be synovial membrane or capsule, or impingement can be the relaxed or loose ligament itself getting pressure. Okay. So that is anyway modified by the MWM because it's close kinematic. So it's very easy to apply the MWM and see for which direction it's relieving, and also correspondingly give the functional neuromuscular stability training. Okay. For a patient who has pain on close kinematic chain, like keeping the hand and then doing the push-up, and the subject is having symptom means, I should not keep in open kinematic chain and give ultrasound. Okay. The worst thing that you can do is only that. Okay. Give a wax bath, give an ultrasound or contrast bath. Okay. So these kind of things. Right?
Right. Yeah.
Sometimes in evaluation open kinematic, you might find symptom, okay, when you are doing specific movements, but if you distraction, it will relieve the symptom. So you know that there is an impingement. So that impingement is released during the distraction. So that also.
I've experienced. Yeah, many patients feel that, they feel better when we give distraction to the joints.
Otherwise, movement testing will produce pain. Not range is not excessive, but it will just produce the pain. You just give a distraction, no pain. Okay.
Yeah.
If you give MWM, lateral glide, commonly chosen lateral only, because Mulligan double L is there, MULLI. Okay. So he will choose lateral only. Okay, lateral glide, lateral glide, lateral glide. Okay. For hip also, shoulder also lateral glide. Everything is lateral, except the tibia and the talus, which is medial, and fibula, lateral malleolus is giving medial glide. So think of what is called as mechanics. Okay. Here also, as I highlighted, that position static, position dynamic in the push-up. Okay. And during this, what is the change in the stellate process? Okay. What is the change in the carpal bones? Whether dorsally they are getting prominent, whether volar side it's getting prominent. Either way, both the sides it will be helped with the cohesive tape. You don't have to do a rigid tape at the wrist.
Yes, sir.
Yes.
The next question is by Paramita ma'am. She's asked, in post-Colles fracture, dinner fork deformity is likely to happen. Will it lead to ligament instability of wrist joints?
In this kind of a scenario, deformity is a fixed one.
Yeah.
It will not lead to instability. If it is autoimmune disorders, deformity can lead to further instability, or even degenerative osteoarthritis if we are talking. Okay? So the deformity can progress because of the instability, deformity, and then finally it gets fixed. Dinner fork deformity, which is post-traumatic, the deformity comes after the instability, and no instability will come after the deformity. Okay. If you are suspecting instability to come, it can be like dinner fork deformity has come in the wrist. This itself is a dinner fork deformity only because the carpal row is anterior. Okay, so dinner fork like that. Okay. So in this position, deformity has come. Instability can come in the radioulnar joint, which is adjacent to this. Because this is fixed. This is subluxed. It's fixed. So what can move? Radioulnar joint will move. Or carpometacarpal, which is below. Radiocarpal is not moving. Midcarpal not moving. So carpometacarpal will be trying to become hypermobile, compensate. Okay. But the treatment will be to mobilize the actually stiff joint. If it is ankylosed, then treatment not possible. You will have to encourage the compensation. Other hypermobility is there also. Don't block that hypermobility because patient needs functionally to weight bear on the hand. Okay. So definitely he needs the carpometacarpal extension.
Yes.
And the same way radioulnar hypermobility will help him functionally with supination pronations. Okay. So that way. So that's the reason you will think of dual decisions. Okay, when post-traumatic, whether it is compensatory or it is what is called as pathological. Okay. Yes.
Yeah. Then next question we have by Ritu ma'am. She's asked, so patient age is 29 years, male, professional CA, more use of laptop and mobile whenever he rotates, as well as does extension and flexion of wrist. Clicks come without any pain. And when grips something tightly, clicks come in MCP joint of index finger, only without pain. So please explain what is the cause.
Okay. So absolutely there is no pain. It's only the clicks of the MCP during gripping. We have to go back to what is the functional activity is gripping. What is the muscle for the gripping? Okay. So first thing is whether you want to talk about superficialis and profundus. That means you are missing the role of lumbricals and intraossei. Because intrinsic muscles is always for the stability. They are attached to the proximal phalanx, crossing the MCP. They will create MCP flexion, intrinsic plus push. That is the action of all the three, lumbricals and the palmar and dorsal intraossei. So during the gripping, first which muscle has to be activated is the intrinsic, then only extrinsic. So in the intrinsic activation itself, if the proximal phalanx is subluxing, okay, it will create a click in the proximal phalanx. First of all, when a patient tells that the MCP click is there, you are also palpating and you can get a click. Think of which muscles are attached to the MCP. Because this is an active effort. Subject is doing the contraction. So it is muscle. So which muscle is attached to proximal phalanx? Immediately it should come. It's not the superficialis or profundus. It is the intraossei and the lumbricals.
Yes.
The dorsal expansion, the digital expansion there. Okay, and then to the proximal phalanx. So please think of the relevant anatomy and also see that it is an active effort, so muscle only. So it's easy to see that. And also the subluxation will create a hollow dorsally if it is volar subluxation. So it will create dorsally. Or if it is dorsal subluxation, it will create the prominence of the knuckle. Okay? So then you know that which direction you have to put the rigid tape. And then give the strengthening for the lumbricals. Okay? And the intraossei. First thing is strengthening this. No need to strengthen superficialis or the profundus. And see how the response for the patient comes. If there's a trigger point in lumbricals or profundus trigger point, so it is tight, so lumbricals is getting insufficient. That is the related anatomy there also. So you can examine that also. Okay. Anterior capsule, volar capsule weight became lax. If it is coming anteriorly, means why this has become lax. That is also to be thought of like the annular pulley and the cruciate ligaments. Because for the flexor tendons, we have the stabilizing structures, annular pulleys and cruciate ligaments. Okay. So whether any kind of an insufficiency in those structures are there. That is why the subluxation might come more. Or is it the bone that is actually slipping? Or the extensor digitorum tendon that is snapping? Extensor indicis. Okay. It's actually getting inserted here. Okay. And this is the extensor digitorum tendon. So whether the tendon is snapping, snapping means on the prominence to go side. Okay, tendon will be going to the side. So that will happen with the trigger point in the tendon. That will happen with the laxity of the extensor expansion. So in connective tissue disorders, okay, not in normal adults. Okay. So think of first and foremost, whenever there is a click happening and it is active clicks, think of the muscle that is attached. If I am doing like this and my shoulder suddenly is coming anterior, it means I am actively doing some contraction and then it is coming anterior. So which muscle is attached anterior? I will not ask, why is it coming anterior? It's coming anterior because anterior capsule is lax. It is coming anterior because anteriorly somebody is pulling. If it is fall, hit, and then it comes anterior, means it is pushing from the posterior and is coming anterior. So passive force. Active means it's the same side. So if you see that the finger what madam has described, it's definitely active force. So it clearly tells about the muscle imbalances. And we should see that what should be given as a rehab, as I was outlining. Okay.
Yes.
Always remember the anatomy. That region, which are the structures, which are the ones which are attached. If you are not asking this first question to yourself and you are not doing justice, you are not a specialist. Okay. Always this is very, very important. I am able to answer only because of that knowledge. If that is not there, means all my answers will be like, you don't have to do anything. Huh? Just to go release the dorsal intraceptical point, the patient will become normal. I will also talk like other resources. Okay? So this is like, make sure that you get your thinking process fixed straight.
Yes.
Okay? Yes, that was the last question in that interaction.
Last question. Yes, sir.
Okay, so that is why during the interaction itself, I was highlighting about how we are going to examine. Okay, in fact, all the regions, right from radioulnar to carpal, and then metacarpophalangeal, interphalangeal, all the instabilities, and also about the articular, myofascial, and neural. Importance of impingement in a closed kinematic chain provocation. Importance of what is called as a patients not having pain at all, overuse related symptom provocation. How you can provoke the symptom with adding in compression if it was a closed kinematic. How you can reproduce the symptom by adding a distraction if it was a fatigue induced. And also to keep the broader perspective, when it comes to upper limb, especially hand, more central sensitization is common. Any problem in the hand, central sensitization is more vulnerable. Autonomic changes, they manifest in the hand only. And of course, vascular, arterial or venous, that also comes in hand only. So make sure that everything should be part of the evaluation and the treatment when we are approaching hand instabilities. Okay. And remember that tendinitis comes because of an instability only, either the muscle itself or it is the related capsule and the ligaments. And the same way, neural instability also. So I'm adding on with the different features as every masterclass we move on, so that you apply these principles in the other regions also. In shoulder, I have not shown neural at all much, but in elbow I showed. In elbow, more functional, more MWM, more FNST. Okay, the direction specific strengthening, concentric and eccentric. In the hand, much of eccentric role, very less. Okay, because a closed kinematic activity for the hand means it's just passively supporting for push-ups. All other things are open. Okay. So that is why in open kinematic, concentric is important. In concentric, endurance is important. So that the fatigue-induced proprioception loss will not create the instability. Okay. So that fatigue could be because of vascular. Fatigue can be because of stress, psychological aspects. So keep this in mind, then we can definitely manage best. And the role of cohesive taping, especially because the bones are too close, too many joints, and there is a instability of one bone, you cannot just stabilize with respect to the next bone alone. You have to block the proximal carpal or the distal carpal. Okay. and then see that feedback, the patient will not move in the end range. If the subjects have a habit of doing this or doing this, all this, okay, all these things, definitely it is also going to lead to instability at one stage or the other. Okay, because you are getting capsule to be stretched. So that is the reason there. Same like how a cracking sound in the neck will create cervical instability. So that is also psychosomatic. So sometimes you have to identify that in the patients. That those who have writer's cramp, that's not question. They will get pain in the hand. After that, they will do this to relieve. Okay, and continue writing. It's a mechanical stimulus. Okay.
Yes.
It's a mechanoreceptor activation. Temporarily.
Feels good.
The pain gate will be blocked because the large diameter fibers are taking capsule proprioceptors. Okay. So you will feel that relief that time. Okay? But what happens is in another 15 minutes, fully it will be very, very tough to use the hand. Like maximum like a dead hand will become. And that time nothing will happen. This also. Okay, because this will not happen. At least you need 1.5 to 2 hours interval. Then only another cracking sound will come. So that you cannot do. And then finally it will become pressing. And then as I was telling, okay, all this and giving some rest. And after that maybe again slowly starting or improper technique and then again continue to write. Change of pen. Heavier pen to a lighter pen. Okay, so sometimes might help. Right? So that's how it goes on.
Many people have this habit of wearing those wristbands also. I mean,
Yeah, it helps in writing endurance. Okay. Dr. Sharani was there. But if she wants to write a theory exam where without bothering about a tiredness in the hand, because this is unaccustomed load exam writing is. We never sit with the previous year's question papers and seriously write for 3 hours for practicing. Okay. So we go directly to the university exam, suddenly question paper comes. We think before writing that anyway 2 hours I can finish, that much I don't know. But once you start writing, you will feel like 3 hours is not enough. You need 5 hours. Okay. And unfortunately, between the hand, it will create the symptoms because disuse. It's not at all used. So definitely the wristband is there. It can prolong the endurance. Remember one thing, as we always talk, proximal stability is important for distal mobility, distal activities. So you do stability for the wrist, finger activity is better.
Right.
Okay, the same principle of cohesive taping or bandaging. Okay.
Okay.
Wristbands also does the same purpose. But you should not do too much. You should not do what is called as beyond that segment that is necessary. If you are immobilizing all the 3 and then you are writing, you can complete the exam, no problem. But your hand actually becomes more and more dysfunctional, more dependent on the wristband.
Right.
And more long-term problems. Okay.
Yeah.
This way that evaluation and specific focus there is important.
Yes, sir. Right.
I've covered almost every aspect, okay, with the hand. So what's important here is to see that closed kinematic examination will not be there much. Okay, it will be open kinematic, and then MWM is useful. If you are using FNST, means strategic. First the intrinsic muscles, then the extrinsic, and then next one neural, depending upon the region of instability. Medial side instabilities, then ulnar nerve. Lateral like scaphoid instabilities. You can think of median. Okay. And posterior lunate dislocation posteriorly, or it could be the radioulnar instabilities will affect the radial nerve. Carpometacarpal with the dequervance disease can also affect the superficial radial nerve. Okay, so that is again part of the tendons that goes only. So articular is the carpometacarpal. Okay. So how we are going to see for provocation of instability is to give the glide or give the distraction. Want to relieve the instability, compression. Impingement is there, then compression will be provocation. Distraction will be relieving the system. Okay. So that will be the outline: articular myofascial neural, loading, unloading, activating and inhibiting. And it's a very small region, but what is important here is to see that mind, the central sensitization is also a bigger picture. So people with writer's cramp, they benefit with mirror therapy. They benefit with graded motor imagery. So this is absolutely you should try it out, okay? Because it's also part of complex regional pain syndrome type 1, which is a vascular mediated. Try to see that.
Yes.
Right. Those who have done the hand rehab masterclass, you will feel this is much more easier, except the fact that the stabilization purpose, okay, that additional one. Otherwise, you will see that the hand is multidimensional, where the symptoms and everywhere it can come. Foot also is same. It's more complicated. Okay? You will have symptoms, systemic disorders also. Foot changes will come, right?
Yes.
Post-traumatic like pseudox dystrophy or post-traumatic which is inner folk deformity. After immobilization, if there is an instability, always see that there may be an autonomic dysfunction. Okay, so that patient will require the thoracic spine interventions. As we saw in the dysautonomia specialist. That was.
Yes.
Of course, the thoracic spine separately, we are bringing up another package, masterclass package. It was announced today only. Dr. Nitin Kumar sir was advising today that why can't you take specifically thorax ribcage dysfunctions on this somatic part. So I thought there's a good time between the October 25 to November 5, but I don't want to take too much near the Diwali. So 31st is okay. So then after that 10th November start with the osteo manual therapy, cranial, right? So that is also another course which actually fulfills all the regions, like cervical was there, lumbar was there, pelvis is over, now thorax is there. So that is covered. And pulmo manual therapy was there, which is for visceral, which physiological one. Somatic part is getting covered. And the next one, the extremity already done, upper extremity, lower extremity. Now instability also, it's covered extremity. Clinical disorders also, extremity-wise common disorders we have covered.
Yes.
It's getting the complete picture here. Okay. So, coincidentally, after seeing the skeletons, I got the idea that thoracic cage also you can take us. Okay. Right. So try to see that everything is part of the, it's like not just the hand instability. So you would be a person who is having the instability in the hand. Okay?
Yes.
Then only you can better handle, so that long-term recovery is better. Don't judge it, try to judge the history. Okay? It is like telling that choosing a partner by parents' choice. Okay? Absolutely parents' choice. You never speak to the person at all. Never look at the person also. Just present it. You're not examining. Observation. Palpation, I am not coming in the picture, like, don't have, you know. But what I'm trying to tell is how the person moves well with you. That is the movement analysis. Okay, yes. How they actually communicate, how they respect your values, this kind of thing that you assess by communication. You're actually talking. So without examination, how can you actually diagnose that the person is good or bad? The person deserves your presence all life. And after that, long-term recovery treatment. Okay, there is no complications future. That is comes with the examination. Okay, not just by history alone. History is what the matrimonial ad or the website or even the agent or even the parents. Okay? That is history taking, diagnosis based on history taking. Okay, so don't tell the history and ask me like what has happened in this patient. Okay, so always see that articular, myofascial, and neural. Okay,
Yeah.
so if hypomobility is introvertism, hypermobility is extrovertism. Okay. Muscle tightness and spasm, I have already told. Spasm is that protective nature, over possessiveness, and tightness is that ego. Okay, and trigger point is testing the other person, simply triggering, like active and latent trigger points. Active trigger point is you know that the person gets irritated because of that. Wantedly, you do the same thing and irritate that person. Okay, that is active trigger point. So their problem will be more sensitive, more high response will come, reactions. Latent one is you are not aware. Okay, and without your knowledge, you have just provoked. But you want to test the person, so that is why trigger point is. Neural, it's a tension. How you handle tension between both of you. Okay. So when a tension comes, whether your affection is getting reduced, that means it's neurodynamics altered. Dynamics between you both altered. If tension comes, you are what is called as not taking food, not taking care of each other, not what is called as emotionally expressing on each other. Okay, so outburst on each other. These kind of things will show physiological deficits, neurophysiological. Okay, so everything will come in the picture. Remember that it's all part of how well you take that integrated knowledge into the life. Okay, see the real life examples, and easily you cannot forget that after that. Okay, so that is the way to actually retain the learning as lifetime. I have learned.
Right.
Okay, it's not like with the textbook where some author whom you don't know or sentence are told, so you have to remember, or 5 patients improved, so that is correct. Okay. You can just apply these principles everywhere.
Yeah.
Yes.
Right, sir.
Right. Paramita not coming on screen. Ritu ma'am off the screen. You will tell, no sir, I was on here only attending only. I said you are not on screen. Okay. So anyway, and anyway she is not wearing the glasses, and still she'll be looking at the phone. Huh? That is why she muted the video screen, so that we won't know whether she is wearing glasses or not. Either way, so we'll close today's session.
Yes, sir.
And tomorrow we can come back with another region, okay? And then have the discussions and interactions and the principles. So you got a clear picture now, upper limb, what we are going to do for the step. Okay? That way, at least 50-60% clear. Okay, what examinations will be there, what treatments, how the perspective decision making is going to be. Okay, so that way. So similar things will move on. Lower limb is much more intricate, more what is called as functionally more will provoke your curiosity. Okay. Coincidentally, I am also taking a workshop on functional manual therapy in Patna, so that is there called the
Okay.
November 19. So there asked me that what is the topic which is important. Okay, what is the? I said that functional recovery manual therapy. Functionally, articular
Very
system.
important.
Functionally, myofascial how to treat. Functionally, neural how to treat.
Yes, very, very important.
2 hours I will show. 5 functional activities I will show. Sit to stand, squatting, stair climbing, walking, and one more I said. I think push-ups. Okay. So for upper limb. Or for lower limb only I have put it. All 5 are lower limb. Squatting, sit to stand, stair climbing, walking. Sure. Okay. So the 5 for the lower limb. And these 5 activities, what could be the problem, what could be knee problem which will cause, what will be the ankle problem which will cause, how to apply various techniques to make sure that day 1 the patient will do the squatting again. Okay.
Wonderful.
So identify that and see that. So that is something which is important. So I said that. The other workshop in Chhattisgarh, right? That is on October 24th. So before that, I want to complete the ligament injury here. Go for that's the spinal techniques, spinal management techniques. 1 day, undergraduate students.
Okay.
And then November there is a conference in Mathura, but that is again it's only a lecture where Dr. Siddiq requested to make on cranial neuromanual therapy. Okay. So that was one thing. So this something of traveling is started. All the sessions will be actually available that people can take either option of watching that live because my phone with the Zoom will be on. Okay. And I will be moving this into position so that you can watch the actual workshop. Practice sessions will be interrupted, okay? Then it will continue. But you need to have that full day in the picture. Okay? The Patna is only 2 to 3 hours. But the one in Chhattisgarh, the Raipur one might be 3 hours, then 3 hours in the evening, afternoon. So like that. Every time, trust me, the experience will be different. Okay, what information you have listened previously will be different. All those spinal manipulation, mobilization, everything, spinal, CSMT, specialist course, everything is covered. When we are actually telling for the undergraduate students, which is like 2nd year, 3rd year, and 4th year. Definitely, the way I actually jump into that step by step to make the students understand will really clear all the blocks of thinking process, drainage blocks, like that blocks in our mind. Okay, so it is a must for people interested and dedicated, and you just watch it during that, or take the session video and watch it later. Both are there, so it's a parallel experience. Okay. Right?
Yes, sir.
So, with ma'am, outdoor physical therapist, finally. Yes, ma'am. So, we'll close the session.
Right, sir.
Right, sir.
Okay. Yes, ma'am.
Yes, sir. Right, sir. I will not say I will be on the screen. I was off the screen and I was using my spectacles throughout the session. I was seeing you and listening with headphones. That's
Okay.
why I was.
See you then. Stay smiling.
Okay. Right, sir.
Yes.
Thank you, sir. Thank you, ma'am. Bye, ma'am. Hare
You,
Krishna.
bye. Yeah,
Hare
Hare
Krishna.
Krishna. Thank you, sir.